This 3-year-old Grade 1 stakes-winning thoroughbred filly has concurrent bilateral hind limb lameness and subtle right forelimb lameness as a result of a common problem in racehorses, non-adaptive remodeling of the distal third metatarsal and metacarpal bones. Notice the short, choppy forelimb and hind limb gait. Occasionally a subtle pelvic hike up when the left hind limb hits the ground and a head and neck nod down when the left forelimb hits the ground can be seen. Concurrent lameness is common in many types of sport horses and may cause poor performance rather than overt signs of lameness. A short, choppy stride should be carefully investigated.
This is a 7-year-old Irish Draught Cross Thoroughbred gelding used for dressage and jumping, exhibiting left hind limb lameness which was only apparent when the horse is ridden. Note the toe drag of the left hind limb. The lameness was most obvious when the rider sat on the left hind right fore diagonal. As the horse is going away from us, note the asymmetrical movement of the pelvis with increased excursion on the left side. This horse's lameness was substantially improved by intra-articular analgesia of the tarsometatarsal joint. It is important to be aware which diagonal the rider is sitting on when assessing the response to local analgesia, since the horse may preferentially throw the rider on the diagonal of the non-lame limb. The rider is now sitting on the left front right hind diagonal and the left hind limb lameness is less apparent. But as the rider comes across the school to change direction, she will change diagonal as she has done now, and immediately the left hind limb lameness becomes more apparent, characterized by toe drag and more irregular rhythm. This is a 9-year-old crossbred mare used in a riding school. Initially, the horse is moving with the hind quarters to the right, but this is because the horse's head and neck are turned towards the handler. The important feature to note is the limb flight of the right hind limb. The limb is thrown outwards or abducted as it is advanced. Very obvious as the horse is coming towards us. On the left rein, the horse holds its back stiffly and throws the hind quarters to the outside. The right hind limb is swung outwards as it is advanced. The rhythm is rather irregular. This was a sudden onset problem after bucking whilst being ridden, and it was not affected by any local analgesic technique. Scintigraphic examination of the pelvic region and hind limbs was negative. Post-mortem examination revealed several sites of new bone formation on the right side of the pubis and femoral head. On the right rein, there is a straighter limb flight of the right hind limb. Tending to cross in underneath the body to some extent. This is an 11-year-old thoroughbred cross Welsh show hunter pony. It is being ridden by the owner's groom in a double bridle. It has an odd running type gait rather than a correct trot or canter. With a very irregular type of rhythm. Sometimes the pony can trot normally, but often runs following transitions from walk to trot or from canter to trot. Under all other circumstances, both in hand and on the lunge, the pony was clinically normal. Here the pony is ridden by one of my staff out in the park, with a snaffle bridle and without any pressure. There is an excellent quality canter. The pony is happy, going forward freely, and we'll see a good transition from canter to trot. I did not believe there was anything wrong with this pony and advised no schooling work between competitions, and the pony has been highly successful subsequently.
This 3-year-old standardbred gelding pacer has left hind limb lameness. At the trot, left hind limb lameness, as judged by pelvic excursion or hike, is less obvious than at the pace, but the horse drifts severely away from the affected side. Drifting is a compensatory gait mechanism, and horses generally drift away from the source of pain. When moving away from you, the horse paces, and left hind limb lameness can be seen as a pelvic hike up when the left hind limb hits the ground. The pelvic hike appears to be more prominent when the horse is pacing than while trotting. Many standardbred pacers with stifle lameness have a history of lameness worse on the pace than on the trot. This horse has osteoarthritis of the femoral tibial joints. In slow motion, observe the diagonal two-beat gait, the trot, and the marked drifting of the hindquarters to the right. The horse is drifting away from the primary source of pain, the left hind limb. Next, observe the lateral two-beat gait, the pace, and notice prominent left hind limb lameness without drifting. Usually the pace is a very forgiving gait, and many forelimb and hind limb lameness conditions are less obvious at the pace than at the trot. Stifle lameness appears to be an exception. In slow motion, as the horse comes toward you, he immediately begins to drift to the right. Now he is trotting. Drifting may reduce the need to elevate the pelvis and shift load away from the lame left hind limb. This 3-year-old standardbred filly has prominent grade 3 right hind limb lameness, causing the typical pelvic hike up when the right hind limb hits the ground and pelvic drop when the left hind limb hits the ground. Importantly, notice that this filly has a head and neck nod as a result of prominent right hind limb lameness. The head and neck nod down when the left forelimb hits the ground is a direct result of the horse shifting load cranially from the lame right hind limb. Since the trot is a diagonal two-beat gait, as the pelvis elevates with the right hind limb, load shifts cranially, and the head and neck nod down when the diagonal left forelimb hits the ground simultaneously. Therefore, right hind limb lameness can mimic right forelimb lameness. From the side, shorten cranial phase of the stride, pelvic hike up when the right hind limb hits the ground, and head and neck nod down when the left forelimb hits the ground can be seen. Hoof strike is louder when the left hind limb hits the ground, a sign of right hind limb lameness. This is a 5-year-old thoroughbred stallion with grade 3 left hind limb lameness as a result of osteoarthritis of the medial femoral tibial joint. As the horse trots away, notice the marked pelvic hike up when the left hind limb hits the ground. I often find it useful to evaluate hind limb lameness as the horse trots toward me. Using the horse as a frame of reference as this stallion trots toward you, the marked pelvic excursion up when the left hind limb hits the ground and down when the right hind limb hits the ground can easily be seen. In slow motion, once again observe the marked pelvic hike up, both when the horse trots away and toward you. Notice that the horse carries the left hind limb straight ahead, and there is minimal medial movement of the limb, followed by lateral stabbing. Horses with stifle lameness often carry the limb straight or in a slightly abducted position. Once again, notice how prominent the pelvic hike is when observing this horse coming toward you. Even subtle hind limb lameness can be seen from this perspective. Notice that the pelvis hikes up when the left hind limb hits the ground and down when the right hind limb hits the ground. Up, down, up, down, up, down. From the side, there is a slight head and neck nod down when the right forelimb hits the ground. This can best be seen by using the windows behind the horse as a frame of reference. Horses with prominent left hind limb lameness shift load cranially when the left hind limb hits the ground, causing a simultaneous head and neck nod down when the right forelimb hits the ground. Left hind limb lameness, then, can mimic left forelimb lameness. In slow motion, observe the marked pelvic hike up when the left hind limb hits the ground, and mild corresponding head and neck nod down, a marked shortening of the cranial phase of the stride in the left hind limb, and excessive fetlock excursion of the right hind limb. This is an excellent example of a prominent left hind limb lameness. Notice pelvic hike up, down, up, down, up, down. Prominent left hind limb lameness. This 20-year-old quarter horse gelding has prominent right hind limb lameness, causing a head and neck nod. As the horse trots away and toward you, notice the simultaneous pelvic hike up when the right hind limb hits the ground, and head and neck nod down when the left forelimb hits the ground. The horse elevates the pelvis and shifts load cranially. From the side, pelvic hike up when the right hind limb hits the ground and shortened cranial phase of the stride can be seen. Simultaneous head and neck nod down when the left forelimb hits the ground mimics right forelimb lameness, but in this horse, head and neck nod is caused solely by prominent right hind limb lameness. This 8-year-old standardbred pacer has severe left hind limb lameness as a result of medial femoral tibial osteoarthritis. Notice the severe pelvic hike up when the left hind limb hits the ground and simultaneous head and neck nod down when the right forelimb hits the ground. Left hind limb lameness, as evidenced by a marked pelvic hike, can easily be seen as the horse trots toward you. The left hind limb is carried slightly lateral to the expected arc, typical of many horses with stifle region pain. From the side, marked shortening of the cranial phase of the stride in the left hind limb is seen. Horses with stifle region pain usually carry the limb in a slightly abducted position and may appear to drag the limb. There may be slight external rotation of the limb, and the stifle region may appear more prominent than normal. While trotting, this 3-year-old thoroughbred filly flat racehorse exhibits a hind limb gait abnormality called plating or platting. Notice the abnormal limb flight bilaterally. During protraction, each hind limb is placed in front of and lands directly ahead or occasionally lateral to the contralateral hind limb. Plating can be unilateral or bilateral and is seen in horses with base narrow conformation, but most commonly is seen in horses with hind limb lameness. Horses with bilateral upper limb lameness, such as this horse with bilateral ilial stress fractures, often plate. At the walk, the abnormal hind limb gait is not present. Therefore, evaluation at both the walk and trot is mandatory to evaluate limb flight during lameness examination.
This is an 11-year-old Selle Français stallion, a Grand Prix show jumper, which was performing poorly at Olympic level. He had histories of difficulties in turning to the right and poor flying changes from left to right. The horse is very stiff in its back, throwing the rider out of the saddle. There is a feeling of lack of power. I rode the horse myself and would not like to have approached a large fence without a greater sense of feeling of power. The horse changes correctly from right to left, but not from left to right. Flying changes were consistently like this. The horse was very difficult to turn to the right. And again, a very poor quality flying change with the horse being late behind. This is the horse after infiltration of local anaesthetic solution around impinging dorsal spinous processes in the caudal thoracic region. The horse is now much softer in its back and moving with improved hind limb impulsion and power. It's much more willing. The rider is not being thrown out of the saddle so far. The canter is much softer, and the horse is becoming increasingly strong. The horse is about to do a flying change from left to right, and for the first time gets a correct change. The horse was now very easy to turn to the right and could turn almost on its own length, whereas previously it had been very difficult. Another change from left to right, and again a correct change, whereas prior to the block none of the changes had been correct. See how the horse is becoming stronger in the rider's hand as it's becoming keener and keener to perform. A huge transformation. Yet another change from left to right, and again correct. This is a 9-year-old warm-blood gelding used for Grand Prix dressage. The horse used to be a very expressive, animated horse with excellent hind limb impulsion and engagement, regularly scoring highly in international competition. Here we see that the horse is stiff and stilted. Note the way the rider is being thrown out of the saddle. He's rather a laborious type of gait and a rather unsteady head carriage with lack of engagement of the hind limbs. The horse is somewhat reluctant to canter and responds poorly to the rider's leg aids. When canter is established, it's almost a 4-time canter. There's complete lack of expression in this horse. A horse working at this level should have increased engagement of the hind limb and be much lighter in the forehand. This is the same horse after infiltration of local anaesthetic solution around the sacroiliac joint region. The horse moves with much greater expression and animation. He is more willing and forward-going. The head carriage is steadier. There is increased swing to the back, and the horse is much more in front of the rider's leg. Note the increased swing in the horse's back and the spring to the stride. The horse is now showing a medium trot, which he would not have shown prior to blocking. In canter, the horse has a much rounder outline and the rhythm is more fluent, and there is a more true 3-time canter. The improvement in the canter, however, at the moment is less good than we had seen at the trot. However, as the horse comes up the long side, we'll see it spontaneously change limbs and then change back again on request, whereas prior to blocking, the horse had been completely unwilling to perform flying changes. There are no longer any difficulties in maintaining canter. This is a 9-year-old Irish thoroughbred gelding event horse, which was presented for loss of hind limb action. Note how the horse is moving on 3 tracks with the hind quarters to the left, with the right fore positioned between the left and right forelimbs. The horse has a bilateral toe drag, being worse on the left hind limb compared to the right. Bear in mind that a horse with a hind limb lameness tends to drift to the opposite side of the lame limb. So drifting towards the lame limb is suggestive of a neurological problem. We must also remember that the toe drag of the left hind limb may reflect a neurological deficit rather than lameness. See how the horse is consistently on 3 tracks, with the hind quarters to the left, and is showing left hind limb lameness. On the lunge, on the left rein, the toe drag of both hind limbs is obvious. See the way that the footing is being kicked up. The horse is continuing to drift slightly to the left with the hind quarters to the inside of the circle. On the right rein, however, this becomes more conspicuous, as does the left hind limb lameness. We noted that when the horse was sedated, the tendency to drift to the left was markedly accentuated. Accentuation of neurological gait abnormalities is quite common in association with sedation, whereas lameness tends not to be. Note the severity of the left hind limb toe drag. Here the horse is blindfolded. He's somewhat reluctant to go forward, but we'll see that the gait abnormality is much worse. The horse is drifting severely to the left. This marked accentuation of the gait abnormality with blindfolding is suggestive of vestibular involvement. So whilst this horse may have a genuine mild left hind limb lameness, he has a much more severe neurological deficit.
This 2-year-old warm blood was admitted for evaluation and possible surgical correction of right shoulder subluxation and is a good example of neurological disease in the horse. This horse has dramatic lateral instability of the shoulder joint as a result of damage to the suprascapular nerve and other nerve roots involving the right brachial plexus. However, notice abnormal proprioception or circumduction of the right hind limb. Combination of clinical signs of right forelimb and right hind limb neurological signs place the lesion in the cervical spinal cord and specifically in the cervical intumescence, since in this horse lower motor neuron signs are present. At necropsy, cervical stenotic myelopathy was found. From behind, you will notice marked shoulder instability. While suprascapular nerve injury may cause atrophy of the infraspinatus and supraspinatus muscles, instability results from peripheral or central damage to nerves supplying the brachial plexus.
This is an 8-year-old thoroughbred with aortoiliac thrombosis. The horse exhibits an odd hind limb gait, holding the croup high with a rolling type action. Notice the head nod when the right fore and left hind are bearing weight, reflecting more severe left hind limb lameness. The horse becomes progressively more uncomfortable as lunging continues. When standing still, the horse initially shifts weight from one hind limb to the other, but then more consistently favours the left hind, holding it in exaggerated flexion, but after placing it to the ground, rapidly and transiently transfers weight to the left hind limb to relieve the right hind limb temporarily. This treading behind is quite typical of aortoiliac thrombosis.
This 12-year-old warm blood gelding has an unusual gait deficit in the left hind limb. During breakover, notice the abnormal lateral movement of the left hock and internal rotation of the left hind limb. There is excessive left hind fetlock drop. As the horse pushes off, it appears he is unable to fix or to stabilize the lateral aspect of the left hind limb, and outward movement of the limb occurs. This horse has avulsion injury of the origin of the lateral head of the gastrocnemius muscle on the distal caudal aspect of the left femur. At the trot, severe left hind limb lameness is seen, and at this gait, left hind limb fetlock drop is now less than that seen in the right hind limb. As the horse travels toward you, notice the mild head and neck nod down when the right forelimb hits the ground.
This is a 5-year-old part Welsh show pony. There is an obviously shortened cranial phase of the stride of the right hind limb at the walk. This was much more marked when the pony was ridden than in hand, especially if the pony worked to a contact. If the pony was sedated, this gait abnormality was undetectable. Many horses are more likely to step short on one hind limb when walking to a contact rather than when walking on a loose rein. It might be predicted, given the severity of the gait abnormality at the walk, that the pony would show severe lameness at the trot. As the pony walks past us, the shortened cranial phase of the stride of the right hind limb is extremely obvious. However, this pony was completely normal at the trot, although from evaluation of the walk you would have predicted a moderately severe lameness. This gait abnormality was not altered by any local analgesic technique. Nuclear scintigraphic examination of the back, pelvis and hind limbs was negative. Ultrasonographic examination of the pelvic region and semimembranosus and semitendinosus muscles was negative. The gait was not altered by continued high doses of phenylbutazone. Note the very regular rhythm of the hind limb gait at the trot. The pony is moving freely forward with good hind limb impulsion, without any evidence of lameness. This is a 7-year-old warm blood gelding used for dressage and working at elementary level that presented with a history of reluctance to work rather than overt lameness. Here we see the horse moving in hand, exhibiting rather limited hind limb impulsion. probably lame bilaterally, possibly lamer in the right hind limb. The horse is not stepping under well from behind and is showing limited engagement of the hind limbs. He's turning normally. His forelimb gait looks relatively normal and he's moving relatively loosely through the back, but he shows lack of push from behind. Here the horse is being ridden by one of my staff. He's not going forward properly off the rider's leg and is showing this resistant or nappy behaviour, being unwilling to go forward freely. When he does go forward, there is rather limited push from behind, that is limited hind limb impulsion. The horse has a slight toe drag of each hind limb, kicking up the surface of the arena. As the rider changes diagonal, slight right hind limb lameness becomes more apparent as the rider changes diagonal. As the horse goes into the corner, he becomes increasingly resistant and grinds to a halt. He just doesn't want to go forward at all. Here the rider is sitting on the left front, right hind diagonal, which accentuates the right hind limb lameness. So there's increased drop with the hind quarter of the right hand side. The horse resists again. This is after right hind subtarsal plantar metatarsal nerve blocks. There is now increased forward movement. The horse is stretching out more to the hand. He's moving with increased fluidity and is much more willing. And left hind limb lameness is now more apparent. There is increased drop on the left side of the pelvis. Now we see the horse after left hind plantar metatarsal subtarsal nerve blocks. We can see the horse is much better balanced, he's much more forward going. There is increased engagement of the hind legs, he's moving with increased animation, longer stride length. He's lighter in front and has a better contact with the rider's hand. The whole picture has been changed. He's moving with much greater animation. Even though he's distracted here, he's still going forward freely. He's accepting the bit better. He's more in front of the rider's leg. A higher tail carriage. The horse is stepping under better. And when the rider asks for a half halt, the horse will respond by increased engagement of the hind limbs, in the way that we should expect from a dressage horse. This is a 4-year-old Hanoverian gelding, a potential dressage horse. At walk, this horse looks relatively normal. At trot, however, the horse lacks hind limb power and intermittently, when decelerating, lacks hind limb strength to fix the hind limbs, resulting in the stifle bobbling forwards on both hind limbs. He has a rather sloppy hind limb gait.
Stop him there. Stop him there.
When swayed to the left, we can see that the horse is relatively easily pulled off line. This needs to be a repeatable response to be a true response. And in this horse we can see that this weak reaction can be shown time and time again. The horse is not resisting properly to the tail pull. When pulled to the right, he's also weak, but not as much as to the left. But watch the abnormal movement of the right hind limb as he's pulled across. Better that time than the previous time. Here the horse is being turned in small circles to see whether or not there is any evidence of circumduction. No circumduction of the hind limbs was observed, but they were sometimes placed and also left in rather odd positions.
Okay, and stop.
So this is a rather curious gait abnormality, characterised predominantly by weakness. It was somewhat variable in its severity from day to day,
Stop.
and on some occasions was much greater than that shown here. The purposes of this CD-ROM are to illustrate how conformation, lameness and other gait abnormalities may modify gait, to try and indicate what features to look for which may indicate which is the lame limb or limbs, and to differentiate gait abnormalities that may be due to mechanical or neurological dysfunction rather than pain. It is important to recognise what is normal and what variations there may be due to conformation, breed, athletic ability and the stage of training. We focus on evaluation of the gait at the walk and the trot, since these are the paces at which lameness is usually best manifest. This is a 7-year-old thoroughbred gelding used for general purposes. Here we see the horse at the walk. The normal walk is a 4-beat gait, the sequence of footfalls being left hind, left front, right hind, right front, with a regular rhythm. The hind limbs follow the forelimbs, either tracking up or over-tracking. That is, the imprint of the hind limb, foot, is placed in or in front of the imprint of the ipsilateral forefoot. The slow pace of the gait allows evaluation of stride length and the degree of sinking of the fetlocks. Lameness may result in decreased sinking of the fetlock of the lame limb due to pain, or increased sinking due to loss of support from the suspensory apparatus, or, less commonly, the superficial digital flexor tendon. Assess the way in which each foot is loaded. Does each foot land squarely? Is the limb flight of each limb straight? A normal horse turns easily, with even loading of each limb,
Now the same thing in trot.
whereas a horse with foot pain in particular may favour the lame limb when turning. Each gait should be assessed from behind, in front and from the side to get an appreciation of the whole horse. It is usually necessary to develop a system for evaluation of the horse's movement, focusing first on limb flight and foot placement of the forelimbs and hind limbs. Observe breakover. Then focus on movement of the head and neck. Some horses with a naturally rather choppy forelimb gait may rock slightly from side to
Once again,
side with
please.
each stride. This may be most obvious in trot, resulting in movement of the head and neck every time each forelimb is loaded. Normally, however, the head and neck are relatively still. Focus on movement of the hind quarters, which should be symmetrical. However, if the horse turns its head towards the handler rather than looking straight ahead, the horse may appear lame, either in front or behind, due to uneven loading of the limbs, particularly the right front if led from the left, or the left hind. It is important that the horse moves at an even speed, neither too slow or too fast, and that the head and neck are not over-constrained by a handler. If the horse moves too slowly, the gait may become falsely irregular, and if the horse moves too quickly, lameness may be masked. The handler must allow freedom of the head and neck so that abnormal movement is not obscured. If the horse is too fresh or exuberant, subtle gait abnormalities may be masked, and it may be necessary either to work the horse and then re-evaluate it, or to mildly sedate it. The trot is a 2-time gait, the horse moving in diagonal pairs. In a normal horse there is natural animation and lift to the stride, and looseness of movement through the horse's back. Horses track straight, the hind limbs following the forelimbs. The tail is carried straight. In order to recognise loss of action due to subtle forelimb or hind limb lameness, it is essential to develop a feel for the type of gait any particular horse might have, For example, comparing the loose, animated, exuberant paces of a warm-blood horse to the more rolling gait of a standard-bred trotter. Lunging allows assessment of how gait is modified by being on the turn. It is useful to assess how the horse moves on both soft and firm surfaces, since the footing or ground surface may influence the lameness. Especially if the horse is fresh, it may be safer to first evaluate the horse on a soft surface where traction is not a potential problem. It may be prudent to protect the horse's limbs with boots. A period of exercise is also important to establish how lameness may be influenced by work, staying the same, improving or deteriorating. Most horses can be readily taught to be lunged, even if they have not been lunged previously. It is generally preferable to see the horse being lunged in a circle rather than being led, because the horse usually trots more naturally,
Okay, the other way.
especially to the right. However, this is not always possible. The diameter of the circle is important. The smaller a circle is, the more likely it is that lameness may become apparent. The horse should be assessed on both the left and the right reins, looking for any change in balance or stiffness, rhythm or limb flight. Hind limb toe drag may only be apparent in one direction. Look to see if the footing is being kicked up. Observe the horse's head and neck posture. If the horse is looking to the outside, it may be protecting the inside forelimb. If a horse has a restricted hind limb impulsion due to low-grade lameness and it is asked to work harder, it may be inclined to break to canter rather than to maintain trot. Assessment of the horse in canter may also be useful to evaluate engagement of the hind limbs. A horse with hind limb lameness may be prone to changing legs behind and becoming disunited in canter. Lunging on the hard should only be performed if a safe environment is available. Ideally, the surface should be firm and provide slight traction, as the gravel surface does here. A normal horse may shorten its stride and hurry and become unbalanced if it feels unsafe. Compare stride length and lift of the stride on the hard compared to the soft surface. A normal horse should not significantly reduce stride length. Some horses with bilateral forelimb lameness of similar degree may only show lameness on a hard surface on the lunge, so this is a crucial part of any lameness investigation. It also provides an opportunity to evaluate how each foot lands. This horse is somewhat unbalanced and is inclined to hurry, and is rather irregular in its rhythm, making it rather difficult to evaluate its gait properly. As it becomes progressively more relaxed, one will see that the gait becomes more rhythmical and any slight irregularities in gait disappear. Here we see the horse moving from the gravel surface onto tarmac, so we can appreciate any differences that result from this change in ground surface. The horse is becoming progressively more relaxed and is moving with a slower rhythm, making gait evaluation more easy. Note the way the horse is inclined to slightly look out of the circle. This can be a normal reaction, particularly as the horse tries to balance itself. This is a 6-year-old Hanoverian mare used for dressage and working at elementary level. Ridden exercise is an integral part of any performance-related or behavioural problem experienced by a rider. Some lamenesses, especially hind limb lameness, may only be apparent when the horse is ridden. Ridden exercise is equally important to try to determine if the rider is actually the cause of any gait abnormality. An overly restrictive rider, or a rider unable to ride in balance with the horse, may cause gait irregularities. Assessment of the tack can also be valuable. An incorrectly positioned or fitted saddle, or a saddle that moves excessively, may cause gait restrictions or lameness. This big moving dressage horse is being ridden in draw or running reins which run from the rider's hand through the bit and down to the girth, because this facilitates the rider's control. The horse should be evaluated from all angles, just as when assessing the horse in hand. The horse should be seen moving in straight lines and circles of variable diameter. Pay attention to any change in direction when the rider changes the diagonal on which they are sitting. Many hind limb lamenesses are more obvious when the rider sits on the diagonal of the lame limb. That is, If the horse is lame on the left hind limb, the horse will appear lamer when the rider sits on the left hind, right front diagonal. Watch the horse perform figures of 8 with each circle loop no more than 8 to 10 metres diameter. As the horse changes direction and balance, lameness may become obvious. Here we see the horse in canter, a 3-beat gait. Now we're back in trot. It is useful to perform all the movements of which the horse is capable, since gait irregularities may only be apparent under these circumstances. Here the horse has come to a halt and is going to be asked to rein back. The rein back is a 2-beat gait, the limbs moving in diagonal pairs. The horse should move softly backwards with no resistance, and then in this horse moved smoothly forward to an active working trot. Note the way in which the horse accepts the rider's hand and is soft in the mouth and occasionally mouths the bit. Again, we are preparing for rein back. The horse is stepping back, equal length strides, and then has stopped. And then equal length steps again, rhythmical and even. And then moves smoothly forward into an active trot. Here the horse is moving sideways. This is leg yield. The horse is being asked to move sideways away from the rider's leg, bent slightly away from the direction of movement. Lateral movements such as shoulder in, travers or quarters in and half pass, when the horse moves obliquely forward with the head and neck bent in the direction of movement, are particularly useful to highlight any gait irregularities. The rider has now gone into sitting trot, and the horse has maintained the same looseness through the back and the same acceptance of the bit. The horse is now performing a shoulder in to the right. This is a movement on 3 tracks when the inside forelimb comes in off the track and the horse is bent to the right but is moving towards the left. The horse continued to maintain a regular rhythm. Half pass to the right, the horse is bent to the right, the hind limbs are crossing over, the left hind limb crossing in front of the right hind limb. Note the regularity of the rhythm and the evenness of the stride. Now we're on the left rein, left shoulder in, a little too much bend in the horse's head and neck, but the horse is still maintaining a regular rhythm and maintaining looseness through the back. And now travers or quarters in, the horse bending towards the direction of movement with the hind limbs on an inner track. Again, the horse is remaining soft and supple. Half pass to the left, seen from the front, the horse crossing over both in front and behind and bending towards the direction of the movement. The hind quarters are rhythmically moving and soft and supple. Now a medium trot, seen from behind, the horse taking regular steps but much bigger steps than previously. Medium and extended trot may make apparent either a hind limb lameness due to any cause or a forelimb lameness, particularly that associated with proximal suspensory desmitis. An excellent extended trot, the horse having natural animation and flair, stepping big and coming back in a nice soft way to a more collected trot. Working canter, the horse perhaps not engaged enough from behind, a 3-time beat, very regular, sequence of footfalls in the left canter being right hind, then left hind and right front together, and then the right front, and then a period of suspension. The greater degree of collection will result in a greater period of suspension. In all work, note the suppleness and elasticity of movement of the horse's back. Ask the rider what they feel. I have ridden to a high level and often find it helpful to ride the horse myself, because this may give me a better insight into the perceived problem, which may be easier for the rider to feel than even a skilled observer can see. Here the horse is being asked to work long and low, stretching down through its head and neck.
This 4-year-old thoroughbred gelding, flat racehorse, has mild to moderate left forelimb lameness. Using the horse as a frame of reference, a head and neck elevation or rise when the left forelimb hits the ground, and fall or nod down when the right forelimb hits the ground can be seen when the horse travels away and toward you. Notice the horse also wings out in front. From the side, using the windows behind the horse as a frame of reference, notice the head and neck elevation when the left forelimb hits the ground, and head and neck nod down when the right forelimb hits the ground. In slow motion, the head elevation becomes somewhat more prominent than in the real-time video segment. There is minimal shortening of the cranial phase of the stride in this horse with mild osteoarthritis of the metacarpophalangeal joint. This 6-year-old standardbred pacer has mild right forelimb lameness as a result of osteoarthritis of the distal interphalangeal joint. At the walk, notice the horse has a gait abnormality called winging in that can predispose pacers to interference injury of the contralateral forelimb and may contribute to uneven loading of the distal forelimbs. Lameness is most noticeable at the walk when the horse turns. At the trot, grade 1 right forelimb lameness can be seen. A subtle head and neck elevation when the right forelimb hits the ground, and head and neck nod down when the left forelimb hits the ground are evident. Lameness is most pronounced when the horse decelerates. From the side, mild shortening of the cranial phase of the stride can be seen. Again, as a frame of reference, use the windows behind the horse to observe the subtle head and neck elevation and nod down consistent with right forelimb lameness. This 3-year-old thoroughbred filly, flat racehorse, has left forelimb lameness as a result of a distal medial humeral stress fracture. In this filly, lameness is evident at the walk. Notice the head and neck elevation when the left forelimb hits the ground, and head and neck nod down when the right forelimb hits the ground. This can readily be seen when the filly travels away and toward you, and from the side. Even at the walk, the cranial phase of the stride in the left forelimb is shortened. The cranial phase of the stride in the left hind limb is also shortened as a compensatory measure. In this horse, lameness is more prominent at the walk than at the trot, a finding that may suggest upper forelimb lameness. At the trot, the filly shows moderate left forelimb lameness and a shortened cranial phase of the stride. This 4-year-old thoroughbred filly, flat racehorse, has severe left forelimb lameness as a result of fungal infection of the intertubercular or bicipital bursa. Even at the walk, there is marked shortening of the cranial phase of the stride, a prominent head and neck elevation when the left forelimb hits the ground, and a head and neck nod down when the right forelimb hits the ground. Compensatory shortening of the cranial phase of the stride in the left hind limb is also seen. Shoulder region lameness is characterized by a dropping or buckling forward of the shoulder region. At the trot, severe grade 5 lameness is seen, and lameness is considerably more prominent than at the walk, a common finding in lame horses. From the front, at the walk, notice the filly carries the limb straight ahead and has a tendency to wing in. Most horses with shoulder region lameness travel close, apparently trying to guard or to protect the lame forelimb. This 5-year-old standardbred gelding pacer has primary or baseline right forelimb lameness. At the walk, lameness is most severe when the horse turns, and he prefers to carry the limb while turning. At the trot, a moderate primary right forelimb lameness can be seen, but the horse has a marked short, choppy, bilateral forelimb gait and tends to travel somewhat camped out in front with a rigid back, as many horses do with laminitis or other severe bilateral forelimb lameness. Lameness is progressive and becomes more obvious as the examination progresses. Right forelimb lameness is evident as head and neck elevation when the right forelimb hits the ground, and head and neck nod down when the left forelimb hits the ground. Notice that the head elevates when the right forelimb hits the ground and drops or settles when the left forelimb hits the ground. After diagnostic analgesia of the right distal interphalangeal joint, lameness is now evident in the left forelimb. Now, the horse elevates the head and neck when the left forelimb is weight-bearing and nods down when the right forelimb is weight-bearing, indicating the horse is now switched from right to left forelimb lameness. Diagnosis was severe bilateral osteoarthritis of the distal interphalangeal joints.
This is a 5-year-old Irish Draught cross thoroughbred gelding used for hunting and low-level eventing, showing a moderate right forelimb lameness characterised by a shortened cranial phase of the stride and a marked head lift and nod. The horse lands more heavily on the sound left forelimb so that the lameness can be heard as well as seen. Watch the horse carefully as it turns, since lameness is sometimes accentuated on the turn. The handler is allowing the horse to move its head and neck freely. And here we can see a slightly lower arc of foot flight of the lame limb compared to the contralateral limb. When lunged on a soft surface, on the left rein, the shortened cranial phase of the stride is readily apparent. Despite being on a soft surface, a marked head lift and nod persist. So we have clearly obvious lameness with the affected limb on the outside of the circle. On the right rein, the shortened cranial phase of the stride is less apparent, but there is still an obvious head lift and nod. Note the variable degree of lameness as the speed of the gait varies.
Baseline lameness in this 9-year-old thoroughbred gelding jumper is quite difficult to determine when trotting the horse in a straight line on a hard surface. At other times, the horse appears to be very mildly lame in the right forelimb, but at times mild left forelimb lameness is seen. Horses such as this may have decreased performance without obvious localizing signs of lameness. From the side, occasionally you will notice left forelimb lameness, but then again, you will notice right forelimb lameness at times. Circling is an important clinical tool used to exacerbate lameness and is demonstrated quite well in this horse being lunged in a nice, steady rhythm on a hard surface. When lunged to the left, mild left forelimb lameness is seen. Notice a slight head and neck elevation when the left forelimb hits the ground, and a slight head and neck nod down when the right forelimb hits the ground. When lunged to the right, the horse now shows prominent right forelimb lameness, characterized by head and neck elevation when the right forelimb hits the ground, and a head and neck nod down when the left forelimb hits the ground. This horse has bilateral forelimb lameness worse in the right forelimb while being circled to the right. Bilateral forelimb lameness, worse with a limb on the inside of the circle, is typical of horses with palmar foot pain. Carpal lameness is common in racehorses, and this 3-year-old standardbred trotter shows several important characteristics of lameness originating from the medial aspect of the right middle carpal joint. This horse is affected with carpus valgus limb conformation that may affect its gait and likely predisposed to carpal lameness. Many horses with carpal lameness place the limb lateral to the expected line of limb flight during the late portions of the cranial phase of the stride. Horses are often described as having a wide or abducted forelimb gait, but it is important to recognize the limb is not carried laterally during the entire stride, but placed in a position more lateral than expected during protraction. Abnormal gait is evident at both the walk and the trot. At the trot, notice prominent moderate right forelimb lameness characterized by a typical head and neck nod and shortened cranial phase of the stride in the right forelimb. The horse has a tendency to place the right forelimb laterally and push off toward the left side. When circling, horses with medial carpal joint pain may actually improve when the affected limb is on the inside of the circle and worsen when the limb is on the outside of the circle. To the right, the horse is considerably better than baseline, but to the left, with the right forelimb on the outside of the circle, lameness is equivalent or worse than baseline lameness. To determine hind limb lameness, you must evaluate symmetry of hind limb gait and the relative degree of pelvic excursion when each hind limb hits the ground. Focus your attention on a fixed point of this horse's pelvis. As he trots away and toward you, notice the pelvis elevates or hikes up when the left hind limb hits the ground and settles or drops when the right hind limb hits the ground. As the horse trots toward you, use his top line as a frame of reference. Notice the pelvic elevation or hike up when the left hind limb hits the ground. Drifting away from the lame limb, a common finding in horses with hind limb lameness, is not seen. In slow motion, the pelvic hike up when the left hind limb hits the ground can readily be seen. From behind and from in front, notice the flight of the left hind limb. During advancement, the left hind limb travels medially, close to the right hind limb, and then stabs laterally. This stabby gait is a common limb flight seen in horses with hind limb lameness. From in front, notice the pelvic elevation up when the left hind limb hits the ground. Up, down, up, down, up, down. Once again, in slow motion from behind, watch the pelvic hike up when the left hind limb hits the ground and drop when the right hind limb hits the ground. Up, down, up, down, up, down, pelvic hike, up when the left hind limb hits the ground, and down when the right hind limb hits the ground. From the side, notice the shortened cranial phase of the stride of the lame left hind limb when compared to the right. Using the windows behind the horse as a frame of reference, notice the pelvic hike up when the left hind limb hits the ground, and pelvic drop or settling when the right hind limb hits the ground. While some horses with hind limb lameness shift weight to the forelimbs and show a head and neck nod, in this horse a head and neck nod is not seen. Slow motion video analysis is useful to see limb flight and pelvic excursion, but is not readily available during most lameness examinations. Once again, from the side in slow motion, notice the pelvic hike up when the left hind limb hits the ground and down when the right hind limb hits the ground. Up, down, up, down, up, down, up, down, up when the left hind limb hits the ground. Left hind limb lameness.
This is a 7-year-old warm blood gelding used for show jumping, exhibiting right hind limb lameness. The effect of a circle on hind limb lameness is somewhat variable. We cannot make any assessment about the degree of lameness or its characteristics with the horse at canter, and it is only when trot is established will we be able to make any proper assessment. Here at the trot, we can see marked right hind limb lameness, characterised by an irregular rhythm, marked asymmetrical movement of the hind quarters, a shortened cranial phase to the stride, and toe drag. In my experience, hind limb lameness varies enormously in respect of whether the horse is lamer with the affected limb on the inside or the outside of a circle. This horse has osteoarthritis of the centrodistal joint of the right hind limb. Here on the right rein, we can see that the horse is moving more rhythmically, the right hind limb tending to cross in underneath the body towards the contralateral forelimb. The lameness is less obvious with the lame limb on the inside of the circle. This is a 5-year-old thoroughbred cross potential event horse. In hand, the horse moves symmetrically with equal stride lengths. The right hind toe sometimes catches, especially when the horse is decelerating. However, it is not possible to detect any overt lameness. The picture is rather different when we see the horse moving on the lunge. Here on the left rein, there is an obvious right hind limb toe drag. The horse failed to respond to any local analgesic technique of the right hind limb. Scintigraphic examination of the hind limbs and pelvis was normal. There was no evidence of any neurological gait abnormality. The horse did not respond to phenylbutazone, and the cause of this very obvious toe drag remained undetermined.
This is a 16-year-old quarter-horse gelding team roping horse with right hind limb lameness. From behind, notice the pelvic hike up when the right hind limb hits the ground. This horse has substantial gluteal muscle atrophy, and from behind it appears the horse keeps the right side of the pelvis somewhat lower than the left. In order to determine lameness, however, it is the change in height of the pelvis, or pelvic elevation during weight bearing, that should be observed. When trotting toward you, notice pelvic elevation when the right hind limb hits the ground. From the side, there is mild shortening of the cranial phase of the stride in the right hind limb. Pelvic hike up when the right hind limb hits the ground can be seen using the windows behind the horse as a frame of reference. Circling can be an important maneuver to exacerbate hind limb lameness. When this horse is circled to the left, with the lame right hind limb on the outside of the circle, lameness is minimal. When the horse is circled to the right, however, the baseline right hind limb lameness is exacerbated. Many horses with hind limb lameness are worse with the affected limb on the inside of the circle.
This is a 5-year-old warm-blood cross thoroughbred gelding used for general purposes, showing obvious left hind limb lameness and also a head nod compatible with a left forelimb lameness. There is asymmetrical movement of the hind quarters, obvious sinking on the left side, reflecting left hind limb lameness. There is also an audible toe drag of the left hind limb. There is a head nod on the right fore left hind diagonal, so it would appear that the horse is also lame on the left fore. The horse lands audibly more heavily on the right fore. However, moderate hind limb lameness may also be associated with a head nod, mimicking ipsilateral forelimb lameness. So the hind limb lameness must be investigated first to determine whether resolution of the hind limb lameness affects the head nod. Here we see the horse after tibial and fibular nerve blocks of the left hind limb. The movement of the hind quarters is much more symmetrical, but the head nod persists, and the horse appears lamer on the left forelimb, demonstrating that the horse does indeed have concurrent left hind limb and left forelimb lameness. The left hind limb lameness was associated with osteoarthritis of the centrodistal and tarsometatarsal joints. The forelimb lameness was associated with metacarpal pain. Here we see the horse moving away from us once more, and actually now there is slight dropping on the right side of the pelvis, indicating that the horse has switched lameness to the right hind limb while still continuing to show forelimb lameness. This is a yearling thoroughbred filly showing mild forelimb and moderate hind limb ataxia associated with cervical vertebral malformation of the 6th and 7th cervical vertebrae. With the head elevated, the forelimb gait abnormality is accentuated. Note the floating type action of especially the right forelimb. The horse intermittently catches the toes, especially of the left forelimb, and also stumbles. As the horse turns in small circles, it tends to pivot on the inside hind limb, but there is no evidence of circumduction of the outside hind limb. At times, the horse takes abnormally big steps with the forelimbs. Viewing the feet in close-up, the tendency to have a rather deliberate placement of the hind limbs is accentuated. The tail pull or sway test shows that the horse can be repeatedly pulled offline to the left, reflecting left-sided weakness, whereas when the horse is pulled to the right, it shows more resistance, being stronger. This 12-year-old thoroughbred mare shows a left hind limb gait abnormality typical of fibrotic myopathy. At the walk, there is a shortened cranial phase of the stride, and the foot is placed very deliberately to the ground as the limb is moving backwards. This results in a characteristic sound of the foot being slapped to the ground. In contrast to string halt, there is no exaggerated flexion of the limb. In slow motion, the backwards movement of the limb before foot strike is more obvious. Fibrotic myopathy usually occurs unilaterally, but can occur bilaterally. There is often an area of palpable firmness in the semitendinosus or semimembranosus muscles of the affected limb. Note also that the right hind fetlock tends to drop more than the left hind fetlock at the walk. At the trot, we will see that the horse shows mild left hind limb lameness, and the same backwards movement of the limb before foot placement is still apparent, although less obvious. This is a 9-year-old thoroughbred national hunt racehorse, showing clear evidence of string halt at the walk involving the right hind limb. Note the exaggerated flexion of the right hind limb. The horse lands more heavily on the right hind limb than the left, but the stride length is not shortened. Compare this with the previous horse with fibrotic myopathy. At the trot, string halt is seen bilaterally, with the right hind limb being lifted slightly higher than the left. This gait abnormality was much less obvious at the canter. The horse had raced successfully before and since and had clinical evidence of back pain. Medication of the facet joints between the 16th and 17th thoracic vertebrae and of impinging dorsal spinous processes improved performance, but not surprisingly did not alter the string halt. This is a 3-year-old thoroughbred cross Hanoverian gelding that is a shiverer. At the walk, there is slightly deliberate placement of the hind limbs, but at trot, no gait abnormality was observed. Typically, it is when the horse steps backwards that obvious clinical signs become apparent. There is exaggerated lifting of each hind limb, with abnormal flexion and backwards movement of each limb, in association with elevation of the tail and tremors of the caudal thigh muscles. Clinical signs in this horse were of variable severity from day to day, but were always present bilaterally. In some horses, clinical signs are most obvious when the limb is picked up, and only one hind limb may be affected. Tension may accentuate clinical signs.
This 15-year-old Trakehner gelding exhibits asymmetry in hind limb fetlock excursion. The right hind drops considerably more than the left hind. Fetlock drop of this magnitude at the walk indicates there is a loss of fetlock support, and in this horse it is caused by severe suspensory desmitis. From our observations at the walk, We might predict this horse to show right hind limb lameness at the trot, but in fact he shows pronounced left hind limb lameness without a head nod. Note that the pelvis hikes up or elevates when the left hind limb hits the ground and drops when the right hind limb hits the ground. At the trot, fetlock excursion is pronounced in the right hind limb, a useful observation to incriminate primary left hind limb lameness and shifting of load to the right hind limb. In this horse there is inexplicable, severe bilateral suspensory desmitis, most severe at the time of the examination in the left hind limb. This 4-year-old filly has moderate grade 2 to 3 right hind limb lameness without a head nod as a result of tarsal region soft tissue injury. From behind and in front, notice a prominent pelvic hike up when the right hind limb hits the ground and drop when the left hind limb hits the ground. There is a stabby type of limb flight and the horse does not drift. From the side, notice the pronounced shortening of the cranial phase of the stride in the right hind limb. By using the windows behind the horse as a frame of reference, the prominent pelvic hike up when the right hind limb hits the ground can easily be seen. This 4-year-old standardbred pacer has concurrent left forelimb and left hind limb lameness. Although horses with pronounced hind limb lameness can exhibit a head and neck nod, in this stallion the head and neck nod is simply too prominent to be the result of mild to moderate left hind limb lameness. Notice the pelvic hike up when the left hind limb hits the ground. While left hind limb lameness is obvious, the degree of load shift cranially will not account for the prominent head and neck nod seen. Notice head and neck nod down when the right forelimb hits the ground. Primary left hind limb lameness resulting from non-adaptive remodeling of the distal third metatarsal bone and secondary early osteoarthritis of the middle carpal joint were diagnosed. Ipsilateral compensatory lameness is quite common in pacers.
This is a 3-year-old thoroughbred flat racehorse showing lameness on the left hind limb and the right forelimb. The horse has a very irregular rhythm and a rocking type gait with obvious left hind limb lameness. Note how the left hind quarter sinks lower than the right. The horse also has an obvious head nod when bearing weight on the left front and right hind diagonal. So is also lame on the right forelimb. This rocking type of gait is typical of horses with concurrent forelimb and hind limb lameness of moderate severity. The horse had severe left gluteal muscle pain and right front fetlock joint pain. Note the horse tries to break to canter, which is typical of these horses with concurrent contralateral limb, forelimb and hind limb lameness, and the rocking motion. The horse doesn't know how to adjust itself to avoid pain. So it rocks forwards and backwards.
This 3-year-old thoroughbred colt has upward fixation of the patella. Numerous attempts to manually unlock the patella and aggressive anti-inflammatory therapy have been unsuccessful. Notice the hind limb is held in rigid extension. Because the patella cannot be disengaged from the medial trochlear ridge of the femur, there is excessive stifle and hock joint extension, and because of the reciprocal apparatus, there is concomitant extension of the distal limb. The horse can flip the lower limb forward and land flat on the foot, but while standing prefers to leave the fetlock region knuckled over. The limb is also held in abduction. Mechanical gait deficit resolved after medial patellar desmotomy. This adult horse has a wound over the dorsal aspect of the distal crus and tarsal region and injury of the fibularis or peroneus tertius. In this horse, the fibularis tertius has been completely severed, as confirmed by digital palpation and ultrasonographic examination. The fibularis tertius is an important part of the reciprocal apparatus, and if severed, there can be simultaneous hock extension and stifle flexion, or paradoxical hind limb movement. Notice that during the cranial phase of the stride, the horse drags the left hind limb forward, during which the hock is hyperextended. At the same time, the stifle joint is flexed, confirming the reciprocal apparatus is disengaged.
This is an 8-year-old Danish warm-blood stallion used for dressage and working at Prix Saint-Georges level, exhibiting lameness on the right hind limb. This is a big moving horse with a lot of roll of the hind quarters. With most horses, I find it easiest to assess the degree of excursion of the hind quarters of each limb, focusing more on pelvic drop rather than pelvic hike in the lame limb. This horse is dropping more on the right side, reflecting right hind limb lameness. The horse is tracking straight, but the tail is held slightly to the right. However, I have not been able to correlate tail posture with lameness. I find that pelvic hike may be more obvious when the horse is moving towards you rather than away from you. This is the same horse after subtarsal plantar metatarsal nerve blocks. The movement of the hind quarters is now much more symmetrical, but the tail is still held slightly to the right. This horse had proximal suspensory desmitis. The gait characteristics associated with proximal suspensory desmitis vary hugely depending upon the severity of the lameness and whether one or more limbs is affected. Note the much more symmetrical movement of the hind quarters. The horse is also becoming more exuberant.
This 3-year-old standardbred trotter has concurrent left hind limb and right forelimb lameness. Concurrent diagonal lameness causes an unusual gait resulting in a rocking type gait or motion. In the previous video segment, we showed a horse with concurrent ipsilateral hind limb and forelimb lameness, in which head and neck nod from both components was predictably similar. However, in contrast, in this segment, the horse has left hind limb lameness and right forelimb lameness, causing a paradoxical head and neck nod. Notice the pelvic hike up when the left hind limb hits the ground and drifting to the right. The expected head and neck nod with left hind limb lameness would be a nod down when the right forelimb hits the ground. However, in this horse, a head and neck nod down is seen when the left forelimb hits the ground, indicating the presence of right forelimb lameness. From the side, a shortened cranial phase of the stride in the left hind limb and a pelvic hike up when the left hind limb hits the ground indicate left hind limb lameness. Using the windows behind the horse, notice the head and neck nod down when the left forelimb hits the ground. After low plantar diagnostic analgesia in the left hind limb, there is near complete resolution of left hind limb lameness. Pelvic hike and drifting are nearly completely abolished, but head and neck nod consistent with right forelimb lameness is still present and in fact more obvious than before the left hind limb block. When examining a horse with concurrent forelimb and hind limb lameness, I usually attempt to abolish the hind limb component first using diagnostic analgesia, whether concurrent lameness is ipsilateral or diagonal. Diagonal lameness is common in the trotter. Once again, using the windows behind the horse as a frame of reference, notice prominent right forelimb lameness now, more evident after low plantar analgesia was performed, to abolish the initial left hind limb lameness. This 7-week-old quarter horse suckling has prominent right hind limb lameness as a result of an avulsion fracture of the distal lateral femur at the origin of the long digital extensor muscle in fibularis tertius that has disrupted the reciprocal apparatus. The hock can be extended when the stifle joint is maintained in flexion.